We'll get started here. All right. Well, this has become for over a decade now a very important part of Pancreas Fest. It's our uh, Ruth Brufsky Award for Excellence in Research for Pancreatic Cancer. And as you could see here, our recipient this year is Dr. Anne-Marie Lennon, who is the chair and professor at the Department of Medicine at the University of Pittsburgh. But before we get into introducing her, let's go review with Ruth Brufsky. So this is Ruth Brufsky with her husband, Alan. She was born in New York City in 1939. There's a whole bio, by the way, on the agenda if you want to hear it. So I'm just trying to hit the highlights, but she married her high school sweetheart, and she really was education was very important to her. She taught in underprivileged neighborhoods. She raised her three children. Her son, Adam Brufsky, is a MD, PhD, who's an expert in breast cancer and works over at McGee Women's Hospital here. Family was important to her. She had 8 grandchildren. And interestingly enough, once she raised her kids, she went back to law school. And then she became an education lawyer in Connecticut. So just showing you her dedication to helping people and educating people. And when she unfortunately passed away from pancreatic cancer, the family decided to endow the Ruth Brufsky Fund. Much of it goes to pancreatic cancer research, but they also included a yearly lecture here during Pancreas Fest. And this just shows you our first honoree was from Johns Hopkins University, was Ralph Rubin, and we've had many distinguished leaders in pancreatic cancer field. And this year, I'm pleased to announce that our next leader in the pancreas field to join that list will be Anne-Marie Lennon. So Dr. Lennon did her MD at the Royal College of Surgeons in Ireland. You may notice she may speak with a little bit of an accent, not too bad. She did her residency in Ireland and then went to the Cleveland Clinic and did a residency. Then she went to Edinburgh to do her GI fellowship. And then she made probably the most important decision in her life. Around 2008, she went to Johns Hopkins to do an advanced therapeutic fellowship. And after 2 years, they, of course, recognized her talent, kept her on for the faculty. Oh, and I did fail. Sorry. During that time when she was in Ireland, she did get her PhD in Dublin. I shouldn't. So when I quickly began to know Anne-Marie when she was at Hopkins because of our shared interest in pancreatic cancer and cystic lesions. And I saw her quickly rise to prominence. She quickly became a leader in research with pancreatic cystic lesions and multi-cancer early detection tests. She also became a rising star in their administrative side and became chief of GI there in 2020 to 2023. So she really is one of the few people that you can call the true triple threat, excels both clinically, academically, and administratively. And we were fortunate here a little more than a year ago to recruit her to become our department chair. And we've planning on recognizing her anyways, but I have to say it was very convenient to invite her this year. And she's going to speak to us today about the past, present, and future for pancreatic cysts. So.
Thank you, Randy, for your very kind words. I appreciate it. So I'm going to just start by Randy's spoken about Ruth Brufsky, but when I came here just over a year ago, one of my big aims was to actually meet every single faculty member. And when I made that decision, I probably didn't quite realize how many faculty we have, which is just over 1,000. But one of the first people I met in the first 3 weeks of being here was Adam Brufsky, who is Ruth's son. And Adam, when we met, he was telling me about how impactful his mother was, how important what she had done with her life, which we saw here about being an educator as well as an attorney, and her death in 1994, how that had really impacted the entire family. And I think as we think about pancreatic cancer, and as all of us join here today and look at ways to try to change this, I think Mrs. Brufsky and also her son just remind us how important what we're doing is. And so it is truly an incredible honor today to deliver the lecture in memory of and to celebrate her enduring legacy. So today I'm going to talk about the past, the future, the present and the future of pancreatic cysts. And we actually have come a huge way. So I'm going to start at the beginning, which is bringing us the whole way back to 1992, which is when Dr. O'Shaughnessy and colleagues reported on 4 cases of mucinous secreting pancreatic cancer. Fast forward to 1996, and the WHO formally described these 2 new entities as MCNs and intraductal papillary mucinous tumors, or IPMTs, which rapidly in 2000 were renamed IPMNs. Now, IPMNs and MCNs, as I think all of us here in the audience are aware, account for 2 of the 3 precursors to pancreatic cancer and offer the potential to detect pancreatic cancer earlier. Like one of the biggest challenges in screening for pancreatic cancer is the low prevalence in the population. And the discovery of IPMNs and MCNs offered the opportunity to enrich for individuals at a higher risk of developing pancreatic cancer and potentially help overcome that challenge. So we fast forward to 2006. And here we have the first international consensus guidelines led by Massimo Tanaka, which recommends screening for patients with IPMN. Now, in 2006, this is the data on which the guidelines were developed. And if you have a look here, what you'll see is that some of the series had as few as 12 patients in them. And despite the paucity of data, the authors were able to come up with this elegant algorithm, which recommended that patients with MCNs, main duct IPMN, and branch duct IPMN with mural nodule, dilated main pancreatic duct, and positive cytology or cyst size greater than 3 centimeters undergo surgical resection. They incorporated cytology, but no other markers into the guidelines. And what I hope you're going to see as we go through this, we walk through where we've come from and where we're going to, is that as time progresses, we gain new knowledge. And one of the first things that we learned was that cytology is good, but not perfect. And so you can see here that it has a high specificity for detecting for differentiating IPMNs and MCNs from other types of cysts, as well as for identifying high-grade dysplasia or pancreatic cancer, but it has a sensitivity of just over 60% for both those. And so what this led to was a search for new markers. And in 2004, we have, I think, one of the very important study, which was the cooperative cyst study led by Bill Brugge, which identified the role of cyst fluid CEA in identifying IPMNs and MCNs and set the cutoff as 192. In 2005, the Dutch group gave us more information, and they published data showing that cyst fluid amylase of less than 250 was helpful in excluding a pseudocyst. Fast forward to 2011, and Walter Park published this paper, which provided more data showing that a high cyst fluid amylase level was found not only in IPMNs, but also in MCNs, and therefore could not be used to differentiate IPMNs from MCNs. And 1 year later, we get the second international consensus guidelines. And in 6 short years, you can see how far we've come. From series where we had 12 patients to now data, the authors were able to base the guidelines on data and information over 3,500 patients. So I think this is a landmark paper, and it introduced the concepts of high risk and worrisome features. It redefined main duct IPMN and defined it as dilation of the main pancreatic duct of 5 millimeters or more. And it incorporated EUS, CEA, and amylase in addition to cytology into the management algorithm. So as we move forward, our knowledge continues to evolve and to impact management. And I think I just want to show two examples of serous and MCNs. So if we go back to 2004, this was the recommendations for how we should manage serous. This was published in the Annals of Surgery. And what it said was surgical resection is recommended for all large serous, which were described as 4 centimeters or all, regardless of the presence or absence of symptoms. In 2016, Vincent Rebourg and Philippe Lévy led a large international multi-center study where they brought people from around the world who all pooled their data on serous. And they published this study in Gut, which looked at just over 2,600 patients with serous. And what they found was, firstly, that there were 3 cases of cyst adenocarcinoma, which all came from a single institution. And therefore, they were able to conclude that the risk of malignant transformation in serous is incredibly small, if present at all. They were also able to recommend that serous cysts should only be resected if there are disabling symptoms or when the diagnosis is uncertain. The management of MCNs has also evolved as data has become more available. And so if you remember in the first guideline, it recommended that all MCNs should be resected. And this was because early studies suggested the risk of invasive cancer in MCNs was up to 35%. However, more recent data, such as this large systematic review published in 2016, found that the risk of invasive cancer in MCNs was in fact significantly lower than previously reported. And a study from a group in Italy and the USA found no cancers in asymptomatic MCNs less than 4 centimeters without concerning features. And this led the European guidelines to change the recommendation and to say that it is safe to follow presumed MCNs that measure less than 4 centimeters in the absence of a mural nodule or symptoms. So let's fast forward to 2012. Up until 2012, we had a single guideline. And this all changed in 2015 with the publication of the AGA guidelines led by Sante Vege. And one area of controversy, which we've discussed today already, was the question of stopping surveillance after 5 years. And I think this led, one of the reasons that it was so controversial was not so much the concept, but the paucity of data to either support or refute the concept. So I think we've come a long way since 2012. We now have data that patients with multiple comorbidities, for example, those with a Charleston comorbidity score of 7 or more, have an 8-fold higher risk of non-IPMN related death within 3 years. And these patients should not undergo surveillance. We've also seen a huge increase in the number of pancreatic cysts that have been detected. So this is a study from 2008, and you can see here that incidental cysts were detected in 2.6% of patients undergoing high-resolution CT. Fast forward 10 years, and this is a study done in Germany, and you can see that incidental cysts are detected in up to 49% of patients. And this is due to a number of reasons. Firstly, there's an increase in the amount of imaging tests that are being performed. This is data showing a dramatic increase in the number of MRIs being performed in the United States over the last 16 years. And this data on CTs is similar, with an estimated 93 million CTs performed in the United States in the last 12 months. In addition to the number of scans that have been performed, there's also an improvement in software and hardware imaging technology, which has also led to an increase in the number of cysts that we're detecting. Now, the vast majority of cysts that we're detecting are tiny. In the German study, you could see there were 3 to 7 millimeters and are without concerning features. I think one of the critical questions is, what is the risk of progression of these tiny cysts? And we had a very nice summary of the data just in a lecture before this one. But I'm also going to just show some other data here as well. So James Farrell and colleagues addressed this question in a recent systematic review and meta-analysis, which looked at what was the risk of progression in low-risk branch duct IPMNs. And they found that the pooled instance of developing worrisome or high-risk features after 5 years was 2.9%, while the incidence of high-grade dysplasia or pancreatic cancer was 1%. They then looked at a question is, if these cysts were stable for 5 years, what was the risk of progression? And they found that the risk decreased further to 1.9 and 0.2% respectively. A group of authors in the Netherlands took this a step further, and if you only include low-risk cysts that are less than 1.5 centimeters, they found that the relative risk of developing high-grade dysplasia or pancreatic cancer at 5 years was 0.04. So I think we've made significant progress. But one of the things when you look at this data is the limitations, and particularly in the quality of studies are imperfect. Many of them are retrospective, and the number of patients with long-term follow-up is small. So as we look to the future, I think there is a need for all of us to come together to develop high-quality prospective studies which report long-term data so that we can truly understand the natural history to allowing us to confidently stop surveillance in appropriate patients. So one of the questions that this raised as we think about, we spoke yesterday about the morbidity and mortality associated with pancreatic resections. And one of the key questions and changes I think that has come up in the last few years is looking at alternative modalities for treating patients. And we had a very nice lecture yesterday about the role of ablation. And this started in 2005 with the first publication by Bill Brufsky and colleagues who looked at the role of using ethanol as treatment for pancreatic cysts. And the concept was successful in this and evolved from alcohol alone to a combination of alcohol and other chemotherapeutic agents. And as Dr. Moyer highlighted in his presentation yesterday, one of the challenges was the higher risk of adverse events when alcohol was used. And we've spoken about the need for high quality papers. And in 2017, there's this extremely nice prospective randomized trial where Dr. Moyer and colleagues randomized patients to receiving either alcohol and paclitaxel and gemcitabine versus saline paclitaxel and gemcitabine, and were able to show that they were equivalent, showing that there was no added value in including alcohol. One of the major questions around ablation is, what is the long-term efficacy of this technique? And Dr. Moyer and others have now published longer-term data. In this one, which was shown yesterday, there are 52 patients undergoing ablation from the CHARM-1 and CHARM-2 studies. 69% have long-term response, 21% had a partial response, and 10% had no response, with the data extending between 2 to 9 years. So let's go back. I'm quite certain in this room that we have endosonographers, CT radiologists, and MRI radiologists. And we all spend a lot of time debating about which of our technologies is best. But I think one of the other things that we've all learned is that, in fact, that imaging is imperfect. And many of the classic features that we're taught about to help identify what type of cyst we're dealing with are not always present. And so when we think about a serous cyst, we typically think of that microcystic appearance. For this large study from Jay et al., looking at 2,600 patients with serous cysts, actually found that almost 50% of patients with serous cysts did not have that classic appearance, and in fact had a macrocystic appearance, which could not be distinguished between, which looked identical to an IPMN or an MCN, and in 5% had a solid component, a solid appearance, which looked very similar to either a neuroendocrine tumor or a small pancreatic cancer. If you look at, we're taught that the way we identify branch duct IPMNs is by communication between the cyst and the main pancreatic duct. But again, this is imperfect. So this is a study looking at 880 patients, all of whom underwent surgical resection. And communication with the pancreatic duct was reported in fewer than 50% of the IPMNs prior to surgery. Furthermore, communication between the cyst and the pancreatic duct was reported in 18% of cysts that ultimately were found to be serous cysts, as well as 5% of MCNs. So we said in 2004, Bill Brufsky described the role of CEA. So we need better tests. So in 2005, Bill Brufsky described CEA. But since then, what we've realized is that CEA was good, but it is far from perfect. So you can see here that it has a high specificity, but a sensitivity of less than 60%. And this has led to the developing new devices and markers. In 2013, we had needle-based confocal endomicroscopy, which generates real-time in vivo imaging of cysts. And then in 2017, we have the through the needle microbiopsy forceps. And both of these have very good sensitivity and specificity of greater than 80% for differentiating mucinous cysts from non-mucinous cysts. But if you look at the data more carefully, what we see is that many of these cysts are very large and are typically greater than 3 centimeters. And therefore, a second approach, which could be used in smaller cysts, it was needed to develop new cyst fluid markers. So in 2013, Walter Park was the first author of this paper, which described the role of cyst fluid glucose in differentiating IPMNs from other types of cysts. And this has now been shown to be very promising in this recent systematic review and meta-analysis, having a sensitivity of 93% and specificity of 76% for differentiating IPMNs and MCNs from other types of cysts. And in head-to-head studies with CEA, it is superior. In parallel to this, great strides have been made in developing molecular markers. In 2009, Asif Khalid and Kevin McGrath from the Division of Gastroenterology here reported on the PANDA study, which showed the potential of molecular markers for evaluating pancreatic cysts. And this really was a landmark paper. In 2011, groups simultaneously in Japan and the United States performed whole exome sequencing and uncovered GNAS mutations which identified IPMNs. So let's fast forward to 2022. Where are we then? And this was a paper that was published in Gastroenterology, and it reported that we had, at that point, 22 gene DNA-based next generations panel, and it was evaluated in just over 1,900 patients. So how did it perform? So presence of GNAS, KRAS, and BRAF mutations had 90% sensitivity and 100% specificity for identifying IPMNs and MCNs from other types of cysts, and was superior to either fluid viscosity or CEA. What about identifying high-grade dysplasia or early cancer? Well, the presence of a mutation in p53, SMAD4, CTNNB1, or the mTOR genes had 89% sensitivity and 98% specificity for high-grade dysplasia. Again, the question is, how does that compare to other markers that we use? Well, main duct dilation is something that we typically use, and you can see that it's significantly better than that. A mural nodule is something that we, as endosonographers, spend our life looking for. Again, you can see the performance characteristics compared to that. And finally, if we look at cytology, higher sensitivity with a fairly similar specificity. Well, that was 2022. Fast forward just 2 years. So where did we go then? So we went from a 22 gene DNA-based next generation sequencing panel to a 74 gene DNA RNA-based panel. And I want to share with you, I think and Atert can tell me if I'm correct, but I believe in 2025, we're up to a 94 gene panel at this point. It's been evaluated in real time in over 4,200 patients who underwent EUS, FNA at 47 institutions across the United States. And the most recent findings are very similar to what has been shown before. 95% sensitivity and 98% specificity for identifying IPMNs and MCNs, 95% sensitivity and 97% specificity for identifying high-grade dysplasia. And in addition, new markers have been identified which have exquisite sensitivity and specificity for IOPNs and neuroendocrine tumors. So we know that KRAS, GNAS, and BRAF occur early, while mutations in P53, SMAD4, CTNNB1, and mTOR occur late. But as we look to the future, I think one of the biggest questions is how do we identify that very small number of patients with IPMNs who will ultimately progress to high-grade dysplasia or pancreatic cancer in the future? And an intriguing finding that Atur has reported is that occasionally we're seeing allele frequencies of high-risk mutations such as P53 that occur at a lower level than the allele frequency in GNAS. And this may represent a group of patients who are at high risk of progression to high-grade dysplasia or pancreatic cancer in the future. This is currently being evaluated, and if shown to be correct, has the potential to help us refine screening strategies for patients with IPMNs. Now, I've shown you the markers that are currently available in clinical practice. There are many other promising markers that are in development. Now, one of the problems with cis-fluid markers is that they require an EUSFNA, and that can be challenging in cases where you have small cis or multiple cis. And in addition, in certain parts of the world, EUSFNA is not typically performed in pancreatic cis. Pancreatic juice offers an exciting alternative, and there are several markers that have been identified in secretin secreted or ERCP obtained pancreatic juice. I think this is a really hard thing to actually bring this into clinical practice, but I'm an optimist, and I think it will be, I hope in the future that this can be translated and we'll see some of these coming into clinical practice. Finally, an exciting concept is whether you could incorporate liquid biopsies as part of a screening approach, potentially decreasing the need for cross-sectional imaging or EUS. Many markers, including those shown here, have been evaluated for looking for early cancer detection. And as we think about IPMNs and MCNs, I think the key will be showing that they can detect high-grade dysplasia and very early pancreatic cancer. And we look forward to seeing whether this is feasible. So I hope that you'll agree with me that we have come a long way and we've actually made huge progress. What this also, although it's wonderful as clinicians to actually have much better data on which to try to make our informed decisions, is also created, meaning it has also created problems. The amount of data that we're being asked to see is rapidly evolving and becoming increasingly complex. So when we see a patient, we're now looking at clinical features, new onset diabetes, family history, germline genetic mutations, what is their surgical morbidity, what's their life expectancy, CT, MRI, EUS, findings, what is the change in the cyst over time, CEA, glucose cytology. And as we said, we went from originally KRAS, GNAS mutations to now a 96 molecular marker panel, and Atur is probably going to change it to 120 in the next 6 months. So it is not easy, and I think for experts in the room, this is challenging, let alone as we look at trying to deliver care across the entire of the United States and elsewhere. So I think AI is uniquely equipped to handle a large number of diverse and complex features and could potentially aid in helping make informed decisions. And there's a number of publications out there looking at what's its potential in NCLE and aiding other ways. Other in aiding are helping us make the right decisions. And I just wanted to share this paper, which was published last year in Pancreatology, which gives you the concept of what this could look like. And you can see here, it looks at multiple clinical imaging and molecular features are evaluated. The model then generates a probability of the type of cyst and the recommended management. And in this example, it has a 76% probability that this is a benign serous cyst. In blue, you can see the features associated with this probability, with the highest weight being given to a VHL mutation in the absence of a GNAS and KRAS mutation, followed by the absence of a solid component or mural nodule. In red, it gave a 15% probability that in fact this could be an IPMN and may require surgery. And you can see here the features that led to that probability, which were the presence of a dilated duct and large cyst size. And finally, we can move from a patient to a model level, and you can evaluate the performance of the model based on all of the resected cases. So here you can see that all the cases that had an 80% probability of discharge and 20% probability of surgery were correctly classified by the model, giving you confidence that this diagnosis of a serous cyst is indeed correct. So to finish, we spent a lot of time talking about how do I differentiate IPMNs and MCNs from other types of cysts. We've spoken about how do we manage them? Should we be doing ablation? Should we be sending them to surgery? Should we be stopping surveillance? But as we look to the future, I think one of the most exciting things is, could we imagine a time where we could intervene and stop IPMNs progressing to cancer? And at the moment, we have some groups around the world who are looking at pharmacological interventions, such as using Solindac to prevent progression. Another concept is could you vaccinate a patient after genetic insult and intercept and potentially prevent the development of pancreatic cancer? We know that KRAS mutations are common not only in IPMNs and MCNs, but also in PANNs. And I think it's very exciting to see this KRAS peptide vaccine trial, which is now enrolling individuals with high-risk IPMNs. So in summary, I think we've come a long way since 1992. We still have further to go, and I think I hope the future is all of us coming together, doing well-designed prospective trials with long-term outcomes, so that we can truly, for the next set of guidelines, we can actually have high quality data on which to base these guidelines. So thank you so much. It's a great honor, and I appreciate the invitation.
So this was an outstanding lecture, and wanted to honor her with this.
Thank you. Like your hand. We got a picture. Thank you very much. Thank you, Randy.
Oh, no, I think we probably have a couple minutes for if there's any questions out there, and then we'll break for lunch. So
On the lunch.
yes. Okay. She'll take questions afterwards here, but I think Milena do you have an announcement?
Small subset of the audience. So lunch for everyone is out there. If you're going to the CAPER board meeting, apparently it is now changed in location. It's going to be in that lower lounge. So meet down there.